Hello dear colleagues, welcome to my YouTube channel. Today I would like to talk about the Virchow Robin spaces. The Virchow Robin space is named after Rudolf Virchow and Charles Philip Robin. Virchow Robin spaces or perivascular spaces surrounds the walls of vessels as they occurs from the subarachnoid space through the brain parenchyma. Rudolf Virchow was the first to provide a detailed description of these microscopic spaces between the outer and inner middle lamina of the brain vessels. Charles Philip Robin confirmed these findings in 1859 and was the first to describe the perivascular spaces as channels that existed in normal anatomy. Virchow Robin spaces are commonly seen at magnetic resonance imaging and may sometimes be difficult to differentiate from pathologic conditions. Knowledge of their signal intensity, characteristics, and localization helps in the differentiation, which is important to correct patient management. Dilatation of Virchow Robin spaces was firstly described by Duran-Farrell in 1843. Duran-Farrell described it as many round small holes always containing a patient blood vessel and located in a hemispheric white matter. He believed that it was caused by mechanical compression of cerebral tissue related to the dilatation of the blood cerebral vessels during repetitive cerebral congestion. These spaces do not communicate directly with the subarachnoid space, but they are filled with interstitial fluid which behaves similarly to CSF in MR. Dilated perivascular spaces consist of regular cavities containing an artery. The mechanism that occurs is not well known, but there are many hypotheses in study. From the subarachnoid space, CSF is driven into Virchow Robin spaces by a combination of arterial pulsatility, respiration, slow vasomotion, and CSF pressure gradients. CSF movement into the brain parenchyma drives convective interstitial fluid fluxes within the tissue towards the perivenous spaces surrounding the large deep veins. The interstitial fluid is collected in the perivenous space, from where it drains out of the brain towards the cervical lymphatic system. This highly polarized macroscopic system of convective fluid fluxes with rapid interchange of CSF and interstitial fluid was entitled the lymphatic system, based on its similarity to the lymphatic system in the peripheral tissue in function. Arteries in the cerebral cortex are coated by a layer of leptomeninges that is subtended through a PM major. By this anatomical arrangement, the Virchow Robin spaces of the intracortical arteries are in direct continuity with the Virchow Robin spaces around arteries in the subarachnoid space. In contrast to arteries in cerebral cortex, arteries in the basal ganglia are surrounded by not one but two distinct coats of leptomeninges, separated by a Virchow Robin space that is continuous through the Virchow Robin space around the arteries in the subarachnoid space. The inner layer of leptomeninges closely invests the adventitia of the vessel wall. The outer layer abuts on the glia limitans of the underlying brain and is continuous with the PM major on the surface of the brain and the anteroperforate substance. Veins in the basal ganglia have no outer layer of leptomeninges, which suggests that their Virchow Robin spaces are continuous with the subpial space. Interstitial fluid within the brain parenchyma drains from the gray matter of the brain by diffusion through the extracellular spaces by the bulk flow around Virchow Robin spaces. There is evidence from the tracer studies and from pathologic analysis of the human brain that Virchow Robin spaces carry solutes from the brain and are, in fact, the lymphatic drainage pathway of the brain. Within 2 years, MRI examination of the brain were performed in 30-40 children, and dilated Virchow Robin spaces were found in 53 of them. Among children with dilated Virchow Robin spaces, 15 were diagnosed with headache and 18 with epilepsy. Other diagnoses were less frequent. There are 3 types of Virchow Robin spaces: Type 1 can be found along the lenticular striate arteries entering the basal ganglia through the anterior perforated substance. Type 2 can be found along the path of the perforated medullary arteries as they enter the cortical gray matter of the high convexities and extend into the white matter. Type 3 can be found in the midbrain. It is considered to be dilated when the size exceeds 2 mm, visualized better in T2 weighted images. Rarely the size of the space is so large that it produces mass effect on the adjacent brain parenchyma and it can cause hydrocephalus. Now I want to show you some clinical cases that will present hydrocephaly caused by enlarged Virchow Robin spaces. This patient presents with the symptoms of Hakim's triad. MRI show an important cystic dilation of Virchow Robin space in the mesencephalon. The arrow points to the compression of the third ventricle. Doctors decided to introduce a diuretic treatment by acetazolamide. After 1 year, an evacuation of 33 ml of CSF via lumbar puncture was performed. Given these encouraging results, an indication of ventricular arterial shunt was revealed, preferred to ventricular peritoneal derivation given the history of abdominal surgery. The image of the second clinical case shows a multicystic lesion in the midbrain with hydrocephalus. In this case, a computed tomography scan showed a massive hydrocephalus and non-enhancing tumor in the brain. MRI of this head showed multiple cystic area diagnosed as dilated Virchow Robin spaces type 3, causing an obstruction of the aqueduct resulting in hydrocephalus. The red dot indicates the flow void through the stoma in the floor of the third ventricle, providing the effectiveness and endoscopic third ventriculostomy. The intraoperative view is shown the rim of the foramina of the Monroe and the infundibular recess. The right mammillary body is hidden behind the big cystic formation. A 17-year-old girl was admitted to the hospital with a headache and impaired consciousness. On her neurological examination, left abducted nerve palsy and bilateral horizontal nystagmus were noted. MR imaging showed a multiloculated cyst mass in the posterior fossa. She underwent suboccipital craniotomy for removal of the tumor. However, during the surgery there was no apparent tumor but cystic dilations. Microsurgical fenestration of the cyst for the first ventricle was undertaken. This 50-year-old man was admitted to the neurological department with the right hemihypoesthesia. Magnetic resonance imaged revealed a polycystic lesion located in the left basal ganglia which exerted compression on the third ventricle causing obstructive hydrocephaly. The endoscopic fenestration was made. MR imaging obtained at the 1-year follow-up examination demonstrated a marked reduction in the cyst volume and decompression to the first ventricle. A 49-year-old woman attended the headache outpatient clinic for a tensile type headache. Her clinical examination was normal but EEG showed diffuse slowing of the left hemisphere. She had been examined 15 years previously for similar headaches. CT imaging showed multiple infarcts in left cerebral hemisphere. On careful inspection, the previously reported lesions actually corresponded to extreme widening of Virchow Robin spaces. A 45-year-old male presented with history of severe headache with 2 months. He was investigated and brain MRI showed a multiloculated cystic lesion involving left cingulating gyrus. Considering the atypical location and appearance on MRI, a histopathological correlation was planned. Patient underwent neuroendoscopic interhemispheric biopsy of cyst wall. The cystic area was histologically confirmed to be enlarged perivascular spaces. A 70-year-old man presented with a history of intermittent, brief episodes of severe, sharp, sometimes electrical, lanthanating pain in right V1 distribution. The pain occurred spontaneously but could be triggered by touching the forehead, talking, or chewing. Between the painful episodes, he was completely pain-free. His only medication was carbamazepine 200 mg 3 times daily, which was controlling the pain without side effects. The MRI in brain revealed a cystic dorsal pointing lesion extending into the middle cerebral peduncle on the right side with multiple septations. He was subsequently referred for the neurosurgical management of this lesion. As his pain was well controlled medically, no surgical intervention was planned. A 53-year-old woman reported a 4-month history of visual field loss impairing her ability to read. Automated pyrometry revealed the left inferior gamma-animal quadrant tanopia. Brain MRI showed a cystic lesion involving the right anterior perforated substance and anterior right optical tract. 9 months later, the patient underwent a direct open microsurgical approach with fenestration, which resulted in the immediate shrinking of the cerebral spinal fluid cyst. There was marked improvement in the visual field defect, and weakness of the left arm totally resolved. A 28-year-old woman with a history of recurrent headache was admitted to the hospital for the sudden onset of generalized seizure. On admission, an emergency CT scan excluded presumption of hemorrhage or space-occupying lesions, but showed a cystic-like lesion at the perilimbic right cortex. MR performed after 6 months were interesting given the complete disappearance of the dilatation of Virchow Robin spaces. Magnetic resonance showed a heterogeneous lesion of the low density at T1 weighted scans, and an irregular high density tumor on enhanced T1 weighted images with a Virchow Robin spaces augmentation located on the left temporal lobe. The tumor cells were situated predominantly with the Virchow Robin spaces located in the perivascular space, with circumferential alignments to both large and small blood vessels. Take-home messages. Virchow Robin spaces surround the walls of the vessels and they cross for the subarachnoid space through the brain parenchyma. They can be seen on MR images in all age groups. They may become markedly enlarged. Knowledge of their signal intensity characteristics and localization helps in differentiation from the different pathologic conditions. You can't recognize Virchow Robin spaces if you don't know they basically can exist. Thank you for your attention.